Thank you. Thanks to the organizers of this event, and thank you all for coming today. And thanks for not scheduling me as a lunchtime speaker. There's nothing that could be worse than that. I do notice when we talk about gender equality or gender equity in the workplace, there seems to be a slight gender imbalance here, but I guess when we work in public health, we kind of get used to that. So today's no exception on that account. The advantage of being the keynote speaker is that pretty much I can talk about whatever I want. So since many of the people in the room know iHRIS better than I do, I'm not going to focus that much on iHRIS, but rather talk about the broader context of global health, which iHRIS supports and fits into. And I want to talk about that because we really are at a very unique moment in history. We're at a moment where in our professional lifetimes, and that's supposing we're all going to be working for the next 20 years, we have the opportunity to bring about a world where women giving birth anywhere on Earth have no greater chance of dying than they do today in OECD countries. Also, where infants are as likely to survive in the poorest countries as they are in the wealthiest countries. And where the AIDS pandemic becomes something that children and young people learn about from their elders, rather than from direct experience. And here you can see, this is a slide I'm borrowing from Larry Summers. I figure if it's good enough for him, it's good enough for me. This is a slide that came out of the Lancet Commission on Global Health 2035, and it shows the trajectory of declines in child mortality that are possible by 2035. And we can find similar trajectories for maternal survival as well. And here's another slide from that same thought piece, which shows that by 2035, we can lower under 5 deaths to 16 per 1,000 live births globally, reduce annual AIDS deaths to 8 per 100,000, and also reduce the annual TB deaths to 4 per 100,000. So this is different from what we've experienced in the past in our field. In the past, we were able to talk about incremental changes, and you can see with the Millennium Development Goals, they're all in terms of declines from a baseline. What we're talking about now is really something that's an absolute level that we think we can accomplish. And this is a vision that USAID and the US government are committed to bringing about in partnership with people around the world and with all of you. It calls for everyone's talents, everyone's hard work, and the innovations that you've developed, such as iHRIS, and innovations that you'll continue to develop. So this assumes a certain level of research and development and has a certain faith in the future and the likelihood that we'll continue to find solutions to challenging problems. So this is our health system strengthening results framework in the US government, part of the Global Health Initiative. And the reason I'm showing this is because in order to bring about a vision where we are able to end preventable child and maternal deaths and bring about an AIDS-free generation, we really need to have strong and country-sustained health systems. So then the question becomes, how do we help bring those about? And what we are positing is that those achievements depend on sustained health system performance, and that then depends on people having financial protection, having access to essential services, making sure that people are covered with those services, so not just averages, but reaching marginalized people, underserved people, and that those services are responsive, so we don't have problems of stigma and discrimination and ill treatment by health workers. And that all of those intermediate outcomes will come about from us focusing on the building blocks of the health system, which probably you've all heard about the 6 building blocks, but you can see very quickly that there are more than 6 blocks at the bottom of that chart. The reason is that we also think there are 3 cross-cutting areas of importance. The role of the private sector, the role of the community, and also the importance of prevention and promotion. You could argue that prevention and promotion is a service, which we sometimes do, but to give it an added emphasis, we included it as a unique focus. So One of the things that becomes clear when you think about those intermediate outcomes of a health system is that human resources for health are vital to all of those outcomes. So if we're trying to bring about financial protection, and that means the cost of health services doesn't keep people from using services that they need, and it doesn't push them into poverty. So one of the key drivers of the cost of services is the cost of labor. So we have to make sure that the health workforce is as efficient and that we use the right levels of staff who are trained efficiently and who are managed efficiently for each service. We also have to make sure that the human resources are focused on the services that are essential, because the second goal of service coverage really relies on essential package of services that includes all necessary high-quality prevention, promotion, treatment, and care services. So if we have a health workforce that is not trained or capable of providing those essential services, but rather is focused on a whole different problem set in health, then we're not going to be able to achieve this outcome. Likewise, with population coverage, we've talked, I think, in other instances about the areas that don't have health workers. So I think the World Health Organization estimates there are 1 billion people who are not reached by a health worker. So in order for us to make sure that marginalized, underserved people are reached, we need to make sure that there are workers who are within reach of those people. And finally, responsiveness depends essentially on health workers because they're the human interface that patients face, and they're the ones that do make sure that people are treated with dignity, confidentiality, promptness, and if we don't achieve that with the health workforce, the people who need those services will likely avoid them. So to achieve the essential services for everyone who needs them, to reach the EPCMD, which is ending preventable child and maternal deaths, and an AIDS-free generation, we need to ensure the right mix of human resources to manage and deliver these services. And we need to think broadly about what constitutes the health workforce. So I guess this is something that perhaps is an issue for me because often when we talk about the health workforce, people have this idea of there's a nurse, there's a pharmacist, there's a community health worker. And my question is, what about the economists? What about the policymakers? So the health workforce really includes leaders and managers who set health system priorities and who decide levels of financing. It includes the professionals who design and who site health facilities. It includes the innovators who generate new health technologies, some of you in the room, for example, and the information specialists who make sure we can track human resource and other patterns. So what do we do, really? What are we thinking is the key to ensuring an appropriate mix of competent human resources for health to deliver essential services? We're focusing on several key areas. The first is looking at the issues of low and middle income countries and fragile states and figuring out what kind of models really can address the special needs of countries in those circumstances. And when I say we, in this case, I'm really referring to the global health community, which is looking broadly at how we can collaborate on human resources for health. We're also trying to improve the knowledge base on the transitions that countries are going through, both economic transition as well as demographic and epidemiological transitions. And what is the future of health labor markets? When we talk about someone becoming a health worker, that's an option among many others. So what are the other alternatives that we're, in a sense, competing with? What other markets are we competing with in health for this labor force? And then developing and implementing effective models for transformative education. And we heard in the Pattaya Prince Mahidol Award Conference the emphasis on transformative education of the health workforce, which looks at customizing education to the needs of the community and also making sure that local people are brought into the system. And then improving data and measurement of impact, and that's really the area where iHRIS is so important, as well as fostering civil society advocacy for human resources for health improvements. There's so many interest groups that have a stake in human resources for health policy, and particularly professional associations of different health workers. So how do we make sure that civil society is a counterbalancing force to those really more narrow professional interests of different providers? And then improving public sector stewardship and leadership of human resources for health. And this is where, as I mentioned before, I think we need to look broadly at the concept of human resources for health and think not simply human resource for health equals service provider, but what are the needs of the health system and how do we make sure those human resources are available? So what is USAID focusing on to ensure that we have the right number and mix and distribution of the human resources that are needed for essential services? I mean, first of all, we know that there's a need at the country level to have reliable, up-to-date estimates of health worker density, and also to have costed human resource for health plans. And those plans focusing on essential services, not on how many specialists do we need to treat leukemia or breast cancer or cervical cancer, but what do we need for providing and ensuring essential services? And we also care about the availability, distribution, and performance of health workers, as well as the availability and use of data for decision-making. And that's where iHRIS comes in so critically. We also want to expand the workforce, and that means considering new cadres of workers, task shifting, and team-based models of care. And we want to focus on managing the workforce, including the use of job descriptions, performance management systems, and professional development. We also need systems for sustainable education and training to ensure competency in essential services, and to come up with incentive packages that keep workers on the job where they're needed and among the populations that need them. And we need, lastly, an adequate focus on the private sector workforce. So if we drill down more into the question of availability and use of information on human resources for health, I'd like to illustrate the challenge that we face. This is a slide that we developed. Now, granted, we developed it almost, 2 years ago. But when we developed it, this is in February of 2012, we were using the information available on the World Health Organization website. The information for these 5 countries ranged from 2002 to 2009. And that only gave us the very gross estimate of the density of a combination of 3 different types of workers: physicians, nurses, and midwives. So really, what kind of really good decision-making can we make at the country level or globally when we have this kind of information available to us? It doesn't allow countries to benchmark themselves against other countries. It doesn't allow them to make evidence-based decisions on human resources for health. So clearly there's a need for better information on the health workforce. And let me go to this. What I'd like to turn to is sort of what can be the future. And I think that future is starting already. I'm going to start with a little bit of a story on this. And this is a picture of 2 girls here in the DC area. One is a daughter of a friend of mine, and they were doing a presentation on sort of the misunderstandings between Jews and Muslims. And I got this initially from my friend, who's the mother of one of the girls. And I got it on Facebook several months later from someone in Egypt who had no idea that I knew the people or anything. It's just the information flowing globally is so amazing. And I think that that's the power of today's communications to spread in innovation. And we see that with iHRIS as well. So we see iHRIS spreading, as Kate mentioned, from something that USAID initially funded in 2007 to now something that has a global community of stakeholders and users and is expanding from, it's very funny, when I started preparing for this, there were like 3 different slides that had been prepared maybe a few months apart. And one of them said something like, 14 countries, plus 6 are on the way. Another one is 13 countries. Another one is 20 countries. So, I mean, you can see that it's so fast moving that it's even hard to keep track of exactly what today's status is. But it's a very impressive phenomenon, I would say, and it does show us what's the power of an open source, really useful solution to a problem that countries face. It's even used in countries beyond USAID's sphere of influence. So, for example, Algeria is using iHRIS. And it's free open source technology. It has a global community of users. And because it's open source, there's a community of developers that's also working on improving the software. So this is an early stage because we expect that there'll be more coming in the future. But as Kate mentioned, it's already proven its value in saving countries money in their initial licensing fees, in saving the money in maintenance of proprietary software. And it's enabled countries to understand their health workforce and to improve decision-making. So, for example, in Uganda, the government was able to allocate $20 million to hire 7,000 new health workers. In Zanzibar, the government used data to increase the public health workforce to 30 times the number that the government had originally budgeted. I can only guess that the number they originally budgeted was very, very small. So the 30 times, you have to take into consideration that. I think the future will see the continued growth of iHRIS because the global community is supporting it and because it serves to help improve the quality of decision-making and to understand the dynamics of the health workforce. And because local developers have an interest in working on improvements of this. Now, I think that also dissemination is really critical. And we have here one of the people who's modeling that experience. We featured, highlighted iHRIS in the Global Development Lab's Innovation Fair, which was held March 31st. And CapacityPlus sent someone to demonstrate that. And it's the kind of thing that we want to share because it does demonstrate how we can introduce something of value that then becomes self-sustaining. And in closing, I would just like to reiterate that we have a very bold vision for global health that calls for strong health systems. Those strong health systems really are calling for human resources that are able to design, lead, and operate those high-performing health systems. And human resource information systems provide the data for decision-making, greater transparency, and accountability. Also, innovation is key. The example of iHRIS is something that we want to apply more widely as we find new solutions to challenging problems. It's an excellent example of innovation in human resources for health information, and it contributes to greater transparency and accountability. Thank you.